Hello, everyone. Welcome back to the Rehab Science Podcast. I am your host and orthopedic physical therapist, Dr. Tom Walters. In today's episode, we are going to be looking at a common clinical condition. In this episode, we will be diving into something called gluteal tendinopathy. This is gluteal tendinopathy is cited in some research articles as being the most common tendon disorder in the lower body. I don't know if that's completely the case. Achilles tendinopathy and patellar tendinopathy definitely rank up there, but gluteal tendinopathy is quite common and affects two of our glute muscles, gluteus medius and gluteus minimus. These muscles are back in our buttock region, but they're sort of towards the back and sort of lateral or outside area of our glute compartment. Their tendons then wrap around and attach on the lateral side or outside of the hip on a bone called the greater trochanter. So people who have gluteal tendinopathy have dysfunction of these two tendons, the tendons for gluteus medius and minimus, and their pain will typically be located on the outside of their hip over this bone, the greater trochanter. So if you are, a clinician, a health and fitness professional, a trainer, and you see people, maybe your client, you have a client come in and they're complaining of pain on the outside of their hip, definitely could be gluteal tendinopathy. This is the place that my brain probably goes right away when people have pain in this area. Other things can refer pain there. The hip joint itself can refer to the outside of the hip. So we have to clear that. The lumbar spine can refer there, the lower lumbar spine, L4, L5, L5, S1. And, other structures in the buttock region, neural structures, the sciatic nerve, some of the deeper muscles, some of those can hurt out on the side. So the hip can be tricky in that a lot of these different conditions can mimic each other. But when someone has pain on the outside of their hip, right over that greater trochanter bone, I will immediately, my first suspicion is gluteal tendinopathy. And so the other thing about it is that you can palpate that area. So if you feel the outside of your hip and kind of go back and forth, kind of a forward back motion, you'll find that bony spot, that projection that sticks out, and that is the greater trochanter. And so right there again are where these two tendons attach. There is a bursa there as well. And for years and years, people who had pain on the outside of the hip, it was diagnosed as trochanteric bursitis. So it just meant an irritation of that bursa on the greater trochanter. What we've found in more recent research is that most cases are actually associated with dysfunction of the gluteal tendons. Only about 20% in the ultrasound research are actually thought to be related to true bursitis. So, most likely it's a tendon issue, and with tendons, a lot of our emphasis is going to be on exercises that gradually load and strengthen the tendons and improve their capacity. Those types of exercises from a physical therapy standpoint can not only help make the tendons stronger and improve their capacity, but also can help to reduce pain. But we'll look at other interventions that can help with this as well. So again, pain on the outside of the hip, we want to be making sure to rule out other hip and low back issues that could be causing this pain. And then what we'll see is that people who have a greater risk of developing this, unfortunately, the females do have quite a bit. It's 4 times more likely to occur in females, and especially older females. So kind of from the age of 35, 40 on, so kind of closer to menopause. And so like other tendon disorders, there may be a hormonal component to the development of this issue. When people are overweight, it can increase your odds of developing this. And then one of the things we see from a biomechanics standpoint in rehab is that people who demonstrate increased hip adduction. So if you think about hip adduction is when your leg moves towards midline, towards the other leg. If we see that happening when people walk or run, it can put increased stress on the outside of the hip on those gluteal tendons. And so people who demonstrate hip adduction during walking and running are more likely to develop gluteal tendinopathy. So those are some of the big risk factors. Again, like I said, symptom-wise, when people have this pain, Mostly it'll be pain on the lateral side of the hip. It can radiate down the leg in some cases, but usually it stays pretty localized to the greater trochanter. They will report pain with walking and running, as I mentioned before, with prolonged sitting. So they have to be seated for long periods. And then one of the other really big ones is that people will experience pain when they're sleeping, especially if they're side sleepers and on a more firm mattress or surface. So you can imagine if I have gluteal tendinopathy on my right side, if I sleep on my right side, of course, that compresses the tendons and the bursa and is likely to aggravate my symptoms. If I sleep on my left side, so on the uninvolved side, my right leg will drop into hip adduction. So it will move towards the midline of my body and across. And that position, again, puts stress on those structures on the outside of the hip and can worsen this type of pain. So a lot of cases will cue people, if they really have to be a side sleeper, try to sleep on the opposite side. So again, if you have it on your right side, sleep on your left side, but then put a pillow or something between your legs so that your affected leg, the hip joint, stays towards neutral, which helps to take some stress off of those glute tendons and the underlying bursa. So those are some common symptoms that people will report. When we look at testing for this disorder, in most cases, people won't have imaging, but if you, usually you can kind of identify it with just kind of movement testing and palpation and get them going on a rehab program. But when imaging is ordered, maybe the person's not getting better, maybe it's a chronic issue, it's not getting better, and some people do have more severe tendon tears and may require medical interventions like surgery. So in those cases, ultrasound can be a good option for identifying dysfunction of the gluteal tendons and looking for, is this tendinopathy? Is it a tear? If it is a tear, how severe is it? Ultrasound can be a good option. It's highly sensitive, but it does require that the person performing the ultrasound is highly skilled. So that's the one downside. And sometimes it can be difficult to find someone who's really skilled in musculoskeletal ultrasound in your area. So then really probably the best option is an MRI to look at the glute tendons. And so when we look at dysfunction of the glute tendons, it sort of ranges all the way from, they'll break it down in the research into 4 different grades. So at grade 1 level, we'll see just kind of irritation, inflammation. There's no actual changes to the tendon itself, we don't see any dysfunction in the structure of the tendon. It's just more of an irritation. And this may be where we see kind of a bursitis. And then when we get to grade 2, we start getting into a tendinopathy where we start to see changes in the tendon signal on MRI. A grade 3 level would be a partial tear in the gluteal tendons. And then grade 4 is a full thickness tear. So a tear through the complete thickness of the gluteal tendons. And so when you get up to those levels, what's interesting about the body is that some people have more severe tears and don't have a lot of pain and still do well with rehab. And then you have other people who it becomes kind of a chronic issue and they end up needing, medical interventions. Maybe it's something like PRP, maybe it is surgery. And all the years that I've been a physical therapist, I don't think I've ever seen a patient who had surgery for gluteal tendinopathy, but these operations are reported in the research, so they do exist out there. So again, when we're looking at, this issue, if somebody were to come in, one of the things we can do to look for it is, I mentioned palpation before. Usually the person will kind of touch there, so you don't even have to palpate all the time, but palpating the greater trochanter and putting some pressure there and kind of tracing the tendons back towards the posterior region where gluteus medius and minimus start often reproduces their familiar symptoms. The other thing we'll see is that they'll again report pain with walking. You might also see that they demonstrate a Trendelenburg pattern. So when they put weight on the painful leg, you'll see them, their pelvis sort of dip. They might lean their body towards that leg to try and offload the glutes. So again, if my right leg had pain, gluteus medius and gluteus minimus are our primary hip abductors. So if you think about, if you're standing up, if I wanted to activate my gluteus medius and minimus, on my right side, I would bring my right leg out to the side. That's hip abduction in an open chain situation. My foot's not fixed to the ground. Now, in real life, our hip abductors mostly function in a closed chain format. So gluteus medius and gluteus minimus, when we're standing on our leg, they help to keep our pelvis level and to control our femur, that upper leg bone. So if you have an issue with the tendons, a tendinopathy or a tear in gluteus medius or minimus, you're going to want to take stress off of those. And so one way to do that is to lean your trunk over the affected leg. If you lean the trunk over, it reduces the lever arm on those muscles and they don't have to work as hard. Another way to compensate is to just just not use them, which their function is to help keep our pelvis level. So if I'm standing on my right leg and I don't want to activate gluteus medius and minimus, when I stand on that leg, I'll let the left side of my pelvis drop. So sometimes you'll see people when they walk, their pelvis will kind of drop on the opposite side and it sort of makes their hip jut out on the painful side. And so that's kind of the classic pattern that we see with a Trendelenburg gait pattern. So you may see that. Other tests that we do in the clinic, we will look at resisted hip abduction. So again, if somebody had pain on their right side, I might have them lay on the table on their left side, and I would ask them to bring their hip through hip abduction. So usually I'll lift their leg and kind of show them what the movement pattern looks like, and then I'll ask them to repeat that and look to see if it recreates their symptoms. I may also do a manual muscle test. We know manual muscle testing is subjective and sort of limited, but it can be useful for testing people to see if you can recreate their symptoms and just sort of gauging the quality and the strength of their muscle contraction. So I'll bring their leg up into hip abduction, ask them to hold it there, and then I'll just push down. Again, just a general idea of, how much force can they generate and does it reproduce their symptoms? And then obviously I'll compare to the other side. So those are some of the major kind of tests that are done from a clinical standpoint. So palpating the area, looking at their gait pattern, does it reproduce their symptoms? Do we notice a Trendelenburg or a trunk lean? And then resisted hip abduction in side lying. So once we've determined, okay, we think this is a gluteal tendinopathy, what can we do from a treatment standpoint? So usually the first line of defense is physical therapy, is rehab, and it would be exercises that load and strengthen the hip abductors. So gluteus medius and minimus, we're looking to increase the strength and capacity of those tendons and to help reduce pain. So you're going to see a lot of hip abduction biased hip exercises. So in the beginning, it may be more isometric based. It could be that the person's doing a standing hip abduction with a band around their knees. And so they're pushing out and maybe holding that position. Maybe they're doing a bridge. Maybe they're doing a double leg bridge, but they've got a band around both knees. And so at the top of their bridge, they push their legs apart to help activate their hip abductors. It could be something like a side plank. It could be a modified side plank where your knees are bent, working up to a full side plank. And this would be with the painful side down. So the bottom leg is going to push into the ground, which helps to not only strengthen your trunk muscles on the bottom side, but also your hip abductors. So you might see exercises like that. As the person gets to where their pain is getting better, is reducing, and their strength is improving, we may have them do just open chain hip abductions, just laying on their side, lifting their leg through hip abduction. They may again do that with a band. They might start doing things like single leg squats, single leg deadlifts, different exercises like that. So gluteus medius and minimus, there's a lot of focus for a number of conditions. So it's pretty easy to find exercises for these. I've got a couple of YouTube videos that show some of the best ones that I've seen with patients over the years, and I'll put a link to those videos down in the show notes. So if you're working with a client who you think has this, or maybe you have it yourself, those two videos will show you some exercises you can start with. Also, my book does have a gluteal tendinopathy program. It's the first program in the hip chapter, and takes you through 3 phases, includes a lot of exercises we would prescribe in physical therapy. So I'll put an Amazon link down in the show notes if you want to check that out as well. So exercise is usually the first line of defense, and it's mostly focused around gradually strengthening the hip abductors, gluteus medius and minimus. Other interventions that have good research, one is PRP, so platelet-rich plasma. A PRP injection actually has a decent level of research support for lower grades of tendinopathy, before we get to a tear. So if we just see a tendon sort of irritation, changes in the tendon signal, but not a tear, PRP can be worth considering. So you'd reach out to your orthopedic doctor. Usually you can find people in your town who perform PRP injections. Shockwave therapy is another one that's gaining more research for tendon disorders, connective tissue disorders like plantar fasciitis, tennis elbow. And so we see some for gluteal tendinopathy. Shockwave therapy has about the same level of evidence as exercise. So again, start with exercise because it's the cheapest option and the easiest. You can perform it on your own. But if you're, just not getting all the way better, or if you've got a more resistant case, then looking at these other interventions, like shockwave therapy and PRP can be something to consider. There are cortisone injections. A lot of people, probably in most cases, that's what a doctor will end up recommending if the person doesn't get better from rehab, is a cortisone injection. Always the worry with cortisone injections is that they do weaken connective tissue like tendons. So if you're just getting one, probably not a huge deal. Cortisone injections often give good short-term results. So if your pain is really severe, maybe the pain's really severe and you can't even do much in rehab, you're having a hard time even functioning and walking around, then that cortisone injection could be helpful. They have good short-term results. The effects usually last somewhere between 3 to 6 months. So not forever, but enough to kind of get you going in a lot of cases. And usually your doctor will talk to you about this. You don't want to have a bunch of cortisone injections because it can increase the likelihood of having a tendon tear just because it does weaken connective tissue. So those are, from a non-surgical standpoint, those are some of the best interventions. So PRP, shockwave therapy, exercise, and cortisone injections. There are these different procedures where there's open procedures and endoscopic where they'll go in and, work on the bursa. They can release the IT band. Again, I haven't had a patient who's had these. They are discussed in the research, but I'd be very apprehensive to recommend surgery to someone who, has gluteal tendinopathy. If they start getting up into the more severe tears, like say someone has a full thickness tear, then that may be a situation where, if they're not getting better and it's been going on for, maybe more than 6 months, more than a year, then thinking about a tendon repair may be something to consider. And most orthopedic surgeons, if you find someone, a lot of them will be good about not just having you jump into surgery for this. They'll take you through rehab and PRP and shockwave and cortisone injections. They'll help you kind of guide you through that process, and most will only recommend surgery if, you just have a case that's just not getting better for a really long period of time. A lot of these connective tissue disorders can take up to a year to get better. So you really have to try and be patient and just stick with it and, stick with the exercises and really modifying behaviors. That's a huge part of tendon rehab, is modifying behaviors in life that are aggravating the issue and trying to modify those so you're not continually flaring it up. So for a lot of these, for gluteal tendinopathy, for a lot of people, it's, managing walking and running volume. So you may have to reduce your volume. You may have to run on flat surfaces instead of hills, just look at changing some of those things. You may have to, if you're in a job where you sit for long periods, try to take breaks really frequently so you're not just aggravating the area. If you're a side sleeper, again, try not to sleep on the side that's affected. If you sleep on the opposite side, put a pillow between your knees so you're not putting increased stress on the tendons. These lifestyle things, if you don't modify them, you will just keep the tendon in sort of a irritated state, and it will be really hard to heal. So exercises and some of these interventions are important, but what you're doing the rest of the hours of your life are arguably even more important for getting a lot of issues in the musculoskeletal system to heal and calm down. Okay, so that is a kind of a quick summary of gluteal tendinopathy, one that I like to talk about because, again, I'll put a link to the one of the research studies, a big systematic review that I was looking at on this issue that cites gluteal tendinopathy as now the most common tendinopathy in the lower body. So more common than Achilles tendinopathy, patellar tendinopathy. So it's one that we're seeing more and more of, especially in kind of middle-aged and older females, but one to be on the lookout for. If you work with health and fitness related clients, you'll probably come across this at some point. So I hope this episode was helpful to you, and I will see you in the next one. Bye.